Hello and good evening, everyone. Good morning and good afternoon to those joining us from other time zones. I'm Anumeha Srivastava, and I'm happy to welcome you all to our May Stroke Month webinar special, Advancing Stroke Care in India, the Evolution, Challenges, and Global Insights. Thank you all for joining us today on a working day. I would quickly introduce myself before I go on to introduce our two esteemed panelists who have taken the time to be with us today. I am Anumeha Srivastava. I'm the Chief Customer Officer for Qure, and I now lead the Neurocritical Care Vertical, which focuses on stroke. Qure.ai, as you know, is an AI company working over the last 7 to 8 years in advancing early detection and diagnosis for diseases using AI as the mainstay in our products. But I'd take a few minutes to welcome our esteemed panelists today. Dr. Jeyaraj Pandian does not need an introduction, but I would still take a few minutes to talk about your work, sir. He's a professor and head of neurology and principal at Christian Medical College, Ludhiana, Punjab, in India. He's also currently the president-elect for World Stroke Organization and also the immediate past president for Indian Stroke Association. He is a member of Strategic Advisory Group for Non-Communicable Diseases at World Health Organization. He is the National PI for Indian Stroke Clinical Trials Network. Dr. Pandian has made significant contribution to stroke care services, epidemiology, and increasing the rates of thrombolysis in low and middle income countries, India included. He was conferred the WSO Global Stroke Services Award in 2020 for his contributions to the field of stroke. So we are very happy to have you here.
Yeah, thank you.
I would also take the time to introduce Dr. Dheeraj Khurana. Dr. Khurana is also a professor in the Department of Neurology at PGIMER, Chandigarh. He's in charge of the multiple sclerosis program there as well. He's vice president of the World NCD Federation, and his special interest areas are acute stroke, neurosonology, and multiple sclerosis. He has established the PGI Stroke Program and Neurosonology Lab, as well as the MS Clinic at PGI, Chandigarh. He has published more than 110 papers in national and international journals, where he was the principal investigator for more than 15 valuable clinical trials and observational studies. In 2014, he received the Practicing Physician Quality Award at the 66th Annual Meeting of AN, Philadelphia, USA. He has mentored and assisted with the setting up of stroke program for the government of Punjab and Haryana. He is also a past president of the Indian Stroke Association. So we welcome you as well.
Thank you, Anumeha.
It's really nice to have both of you here. As you heard, the topic of today's session is advancing stroke care in India. May is celebrated as the Stroke Awareness Month, or Action on Stroke Month, as we call it this year. So we would like to take you through the stroke care ecosystem and scenario in India, with a special focus on how the policy and frameworks have evolved over the past couple of years. Our speakers would talk about the challenges that they see in day-to-day implementation of guidelines, how the country has built resilient practices around these challenges, and what both the West and the developing countries can learn from India, and vice versa. What has India taken from the best of practices globally? So for the first panelist, I'd request Professor Dr. JP to talk about the national policy, advocacy efforts, and all the work that he's done over the last couple of years in stroke care in India, with a special focus on the accessibility aspect of thrombolysis treatments in India and the work done so far in the country. It would be great to hear also about the technologies such as telemedicine that play a role in the access of thrombolysis.
Yep. Thank you very much. Yeah. So in terms of national policies for stroke, the government of India, we have a program called National Program of Non-Communicable Diseases. And, it was started about 10 years ago, and it has gone through multiple changes. And in that, stroke is also an important component in the NCD. In the early years, it was primarily focused on prevention, but after multiple revisions, and a lot of lobbying, like Dr. Dheeraj and many of us. Uh, uh, it has come to a level where the care, the stroke unit, to be part of a district hospital, government hospital, and stroke unit, and it is called vascular unit, where it can keep heart attacks as well as stroke patients. So that is a major advance, I would say. Uh, there are several states which are implementing that, but still we have a long way to go. The second important policy change was the guidelines by the Ministry of Health and Family Welfare, Government of India, New Delhi, and Dr. Dheeraj and me, we are part of that guidelines committee. Recently, it was revised and modified in 2022 November, which has uh, all the, I would say, the guidelines to develop stroke unit in a district hospital, in a tertiary care hospital, the human resources, the training that is needed for all the staff, and the tools that has to be used, and also rehabilitation. Compared to the previous guideline, there is a great emphasis on rehabilitation. So that is another important policy change. Um, the third one is the Ayushman Bharat, our universal health coverage. About 3 years ago, uh, the stroke package was introduced in the Ayushman Bharat, including mechanical thrombectomy. However, the reimbursement was very low, and I chair a committee with National Health Mission, DHR, ICMR, on neurological diseases, and several of the stroke people are members, and other neurologists as well. So we have revised the reimbursement package for stroke care to a reasonable amount, so that even the private players also can join in that program. And however, the rollout takes time because it goes through multiple committees in the government, finance, and multiple advisors, and finally it will be rolled out. And so that is one major change in terms of policy. And the last one is the stroke center certification through World Stroke Organization, and we have partnered with the National Accreditation Board of Hospitals, NABH, and that we have come up with the standards which was released in I think in the G20, just before the G20 meeting last year. We had a Global Stroke Alliance meeting in New Delhi. The standards have been released, and the website portal is ready. Already centers have started applying. Our plan is to certify by August at least 10 centers. It is a joint WSO and NABH program. So these are some of the major policy changes which has happened in terms of stroke care in our country. In terms of scalable solution, particularly to improve the access to thrombolysis, and so that is where we have been working with different state governments. Uh, you may know about the Angel Stroke Initiative, which is a global program. We work with the Angels program. They partner with the state governments and sign MOU and roll out the training process, the capacity building of the district hospital, the doctors, nurses, and the neurologist as well in some other tertiary care medical college hospital. The program has been successful in Haryana and Punjab, where both of us have been leading, and also in other states in our country. About 8 states where the state governments have signed an MOU with the Angel Stroke Initiative, which is a global initiative, and which also incorporates stroke quality as well. Um, and another important thing, which in terms of increasing access to thrombolysis, is the capacity building of the physicians, the physician-led model, which was tested scientifically in Teshpur, and it has been rolled out in many states. And what we have seen is the confidence by which the physicians in these district hospitals are able to thrombolyze stroke patients with some amount of hand-holding, like we have a WhatsApp groups, and there is a big opportunity for technology to come in this urban stroke model, where the technologies, AI technologies, if we can be incorporated and it'll be faster communication and faster reporting of the scans and decision making, which all these things, if you do it very fast, then the outcome improves, the thrombolysis rate improves, and the outcome improves. So these are some of my thoughts on the policies as well as the scalable solutions, including the improving access to thrombolysis.
Thank you, Dr. JP. I have some follow-up questions about some of the things you've mentioned, which are very programs, but we'll talk about that in a couple of minutes. I'll take this time to try and request Dr. Khurana to talk about his experience working extensively on the government side. If you could talk about the prevalence of stroke, specifically the work that you've done in Haryana and Punjab. Are there geographical disparities that impact the incidence or the care? And then talking about the strategies for community empowerment that you've undertaken or how you have seen that they work. That'd be really exciting. Would love to hear from you the critical challenges that you face on a day-to-day basis in terms of accessibility and infra and integrating technologies such as the ones that Dr. JP briefly mentioned, or any others that you have had the experience working in or finding valuable in. That would be very.
Sure. So, thanks for the question, Anumeha. Primarily, if we were to look at the incidents, so yeah, am I audible? Okay.
Yes, we can hear you.
Right. So, the basic, I think we rely upon data, which is the GBD data, which came up a couple of years back. That reflects a huge, I think, insights into how the NCD burden has increased across the span of 30 years, which showed a doubling of the dailies due to the NCDs, and the biggest contribution was for stroke. And it's a big reflection of how the incidence is increasing over the years, and individual state data also reflected the same thing. And the reason why it's important to know states in India is because every state is may in fact reflect small countries across the world, for example, European countries. So that's the importance that we give to the state data. So as far as the North India is concerned, the biggest, I would say, the challenges or the biggest contributors to having high stroke incidence or prevalence in the states of Punjab and Haryana have been the major risk factors. In fact, why I'm referring to the risk factors is that's how we need to work on reducing the incidence and the burden of stroke. And the biggest risk factors, which has been well documented not only in the GBD but multiple studies, is high systolic blood pressures and sugars, high BMI, smoking and alcohol, and of course poor lack of a good lifestyle, poor exercise. So apart from these things, so these go on to the epidemiological side if we need to really look into the factors which are responsible. The major factor, what as Dr. Jeyaraj mentioned, we started working on in the States in a couple of years. What emerges out is, I would say, two-pronged lack of awareness. The two-pronged lack of awareness initially was not only from the public side, but also from the, I would say, from the healthcare worker side. Most healthcare workers in the district setups were, at one point of time, were not initiated or were not even aware how strokes could be treated. Was it possible to treat strokes? So the first thing I think we've been able to achieve over these years is to get the physicians, one is initiated and at least aware of the facts. And even if they were aware, there was a lack of motivation because of lack of facilities. So the second thing, which as Dr. Jeyaraj was mentioning, and he's played an excellent role in, improving the accessibility to treatments. So that's what we were able to achieve in these states, is along with the working with the governments, is to have improved accessibility, making the availability of treatments free, which happened for the thrombolytic treatments. So once the accessibility is there, slowly and gradually the motivation of the physicians and the healthcare workers that improves, because if you don't have the treatments, there is no point in even educating the healthcare workers. And the other thing was, of course, a shortage of manpower, chiefly neurologists, which we know are short in our country. And that was the other major challenge that we faced. The way around it was to train the physicians, the medical internists, in the internal medicine physicians and the medical officers, and of course the supporting staff, including nurses. And as referred to by Dr. Pandian, the role of angels. Angels played a very effective role also in undertaking these trainings for the various levels of the healthcare workers. So once these trainings done, and the lack of infrastructure in terms of stroke units has been a major challenge, which I think quite a few of us understand, that stroke units cannot be provided in each and every district hospitals, and that's one of the highest level of evidence that we have to improve outcomes in stroke. So even they were tackled, and it was finally agreed upon that the CCUs, or the cardiac units, which are already existing in these setups in the district hospitals, would double up as stroke units. So that kind of got taken care of, and models which initially, like for example, started in Punjab, and of course it hugely depends upon the initiative of the government. If they take an interest, it does, everything moves. That's what has been noticeable. And as of now, after especially the program, which Dr. Pandian also mentioned, the NPCDCS, which is now amalgamated into the NCD program. The stroke was initially called as NPCDCS, which is non-communicable diseases, etc. And stroke is now, even the NCD program includes stroke, and that's been a major push by all governments right now. And I think it has been through the various data which has been published, including the GBD data, state-wise data, which has actually helped in this push, which makes us understand the increasing number of deaths which have been happening due to the stroke. So that said, most of the states are now taking at least the states that we've been involved with, and that is actually helpful, because the neighboring state also gets competitive, and they would really like to improve on their stroke services. And Himachal was initially one of the earliest states, and Dr. Padma, we all know the role she played in getting the Himachal program. So that said, about the access to technology, I think that's one major unmet need. Technology, in terms of true technology, has not outreached the interiors of most of the states, and that's one huge area where there's big potential. They are being tested, as Jeyaraj has been leading in Tezpur. There's mobile stroke units, and technology is of course integrated into that. And of course, we may not be able to get mobile stroke units across the country as of now so fast, but the technology, as we see it, could at least reach out to the stakeholders, both the patients as well as the physicians. And there are multi-pronged technologies right now we're talking about, and why they're connecting them through the hub and spoke. And one of the basic reasons why technology is going to be very successful is that we have a very good mobile coverage, almost a huge population which carries smartphones, and even the internet access is quite good as per the data that we have as per the connectivity, and we are getting good bandwidths reaching out to quite a few areas across the country. I think the overarching principle that still, and technology can of course play a role, and we've still not tapped it, is to educate. One is increasing the awareness. That still is needed. Awareness is still not reached to that level where people know that what a stroke could be. And second major thing is where to reach for the stroke. So I think that where is getting slowly tackled. One is when the district hospitals was a normal, usual population will reach out to their government hospital. So if that at one point of time, a few years back, was not offering treatment, it was completely a lack of, I would say, it would be wasted as a stroke patient reaching the hospital and not getting a treatment would be quite dismal. But now, since so many district hospitals are offering, so there's a good chance that a patient reaching the district hospitals. So what if we were to link the technology aspect here, a lot of district hospitals can be linked even if they don't have treatments. Like, for example, you need a CT scan. So a lot of district hospitals may not have CT scans that's what we've seen, although in states like Punjab, most of the civil hospitals now have a CT scan, 7 or 8 districts which they have, but there'll be sub-district hospitals and strokes will reach either of them. So that's one model that we've attempted in Chandigarh also, to educate the sub-district hospitals so that they can at least refer the patients early and fast. I believe this is where technology comes in, and creating more spokes where people can identify and communication between the hub and spoke can happen, and even a rapid referral to the right hospital using technology as well as educating the healthcare physicians in the sub-district levels would and should work, I think, in our country.
Thank you so much, Dr. Khurana. Those were some really interesting insights from the ground. Qure has been dabbling and attempting to build these hub and spoke models, slightly more focused on the private side so far, but we do intend to do more work with district, sub-district, and community hospitals to see if we could build a chain of referrals back into tertiary hospitals that are stroke ready. But your point earlier that you mentioned, Dr. Khurana, about awareness. Everybody, when they say awareness, they think about patient awareness, general population awareness. People often forget the awareness element for physicians themselves, among the many things that they study in medical science. Stroke doesn't always feature in the top of their list, and that's unfortunate. And Dr. Pandian, you talked about the physician-led stroke model. So first, I'd like to ask Dr. Pandian about your experience in empowering physicians around, not just in India, but I know you've done this work elsewhere in Southeast Asia. What have been some of the challenges in implementing a physician-led stroke model? If you could throw some light on that, that'd be very helpful.
Yeah, it is. One is the willingness and acceptance of the physician, because when we talk about stroke care and when we talk about stroke thrombolysis, the first thing is they are very much concerned about hemorrhages, brain hemorrhages related to thrombolysis. That is the first fear that they have. To thrombolyze a patient with acute myocardial infarction is very easy. Look at the ECG and just give the drug. That's all. There's nothing else to read or anything. Yeah, they need to be confident about the CT. They have to depend on others for the report, unlike neurologists, where we can read and take a call about thrombolysis. So first is the fear of complications. Second is the imaging interpretation. So these are the two major challenges, and but slowly it can be overcome, by capacity building. It's one session is not going to help them. At least 2-3 sessions and hand-holding. In Tejpur, the early days, and also after MSU was deployed, almost every day I used to get calls and images used to be transferred and for thrombolysis decision. And after some time, they are managing in their own setup, like the Baptist Hospital. They are helping the Tejpur Medical College now. So I hardly get any calls now. So it is a long process. It takes few years, and similarly with Punjab also, and number of thrombolysis. It's not very high, but there's one district hospital where the physician is there. He's so confident and he normalizes almost equal to some of our tertiary care centers. Independently, he does not consult anyone. Only the patients who need thrombectomy, and so they are referred. And uh, it is a very slow process, but we need to slowly take them with us in terms of training and also reassuring them you need to select the right patient and then provide treatment.
Thank you. We have seen the train the trainer model work in many other disease areas as well. And we know both the Angels program and other global networks are actively focusing on empowering the healthcare workers. What I do see from what you hear, Dr. Pandian, is that since the process is long and behavior change takes time, I think there would be a role that technology can play specifically in the continued handholding aspect. Would you or Dr. Khurana or each of you have any specific ideas to throw out for our audience? A lot of the people here would be technology enthusiasts. So, would you want to throw out ideas or share your experience of how technology can play a role in continued handholding or empowering healthcare workers?
Maybe Dr. Khurana could go first. And
Sure. So, well, technology has been there for, if we look into the examples of the technology worldwide, technology has always been there to assist uh, access as well as educate and increasing awareness. So the biggest example that one is which is existing, and the second I'll talk about how we've been doing it. So is the the telemedicine. So assisted by telemedicine, doctors sitting in neurologists who are stroke neurologists can very easily and in fact with high level of evidence they can detect a stroke and help the physician in assessing a stroke through the scale of the NHSS, as we are aware of. That's one major achievements which have been validated through telemedicine and technology, that a distant physician can assist a patient, assist a physician in assessing and then taking a decision. That's one way of doing it. That's two-way telemedicine, which works really well. The second aspect is what has been also a common experience with all of us is to look at the data which comes in, for example, the imaging as well as the patient if there has been detection in the remote area. And through technology right now, either through simple WhatsApp kind of technology where the images are shared or through cloud where the images can be shared across the network, decision making is going to be easy. And because the images can be seen by either a radiologist or a neurologist on the other side. And this is one of the ways that has been happening even in our setup in Punjab and Haryana, where images and the data gets shared, and decisions can even be taken to ship a patient, for example, from a spoke, which would be a district hospital typically, to the tertiary care center, which may be either places like CMC or PGI. So that's on a routine basis that we've been doing currently, and that at least I believe when changes are seen, that keeps the physicians motivated, that at least patients are being seen and decisions are being taken right in front of them. So telemedicine has to be further, I think, explored and utilized to its full potential, which is not happening currently. And of course, talking of technology, there's the sky's the limit. We could right now we're talking of AI-enabled decision making, which is also happening across the world, and that could be one of the ways where I think could be attempted. And we need to have portals or platforms where even simple AI can help for simple decisions, of course, assisted by physicians if required. not only for diagnostic purposes, but later on completing the continuum, which initially Dr. Jeyaraj also mentioned about rehab. We shouldn't forget rehabilitation. That is one of the biggest things that we are still not discussing much, and is needed for a good percentage of patients, especially in setups like these where in the periphery they're not probably going to get thrombectomy, so outcomes may not be as good, and rehabilitation needs to be worked on at the community level in a big way, which is right now not really there in our setup. So that's where technology, we could talk of either simple things like applications. We are testing one of those kinds in a clinical trial right now, which is funded by the Instruct, where we're using a medical application to teach people how to treat and take care of immediate post-stroke, subacute post-stroke complications. And let's see if that has already shown evidence in a small study, and if this shows what kind of results we get in a larger trial. So things like those, and we are aware that AI-enabled rehabilitation platforms are also getting developed. So something of that sort needs to, I think, be brought in.
Absolutely. Thank you, Dr. Khurana. I started my career also in rehabilitation for stroke, neuro, and spine patients. And one of the initiatives that I've seen work but not scaled yet is community-based rehabilitation.
CBR.
With the help of technology, it can be,
Right.
CBR. And if we could empower primary frontline healthcare workers in doing basic rehabilitation techniques and then referring them to peer advocates or peer trainers, that is a model that we've seen to be effective, but again, hasn't been scaled very well yet.
Agreed.
Dr. Pandian, would you like to add anything on the topic that he mentioned? Should I?
Yeah, I think I'll continue where Dr. Khurana left, and I'll give some global perspective. One is China. China, I think in one of the international conferences, maybe last year, they looked at technology-driven, algorithm-driven stroke care. So they did a cluster randomized trial where med centers were randomized and centers were using their own protocol versus technology-driven, AI-driven diagnosis, algorithm-based treatment, and 6 months and 1 year outcome. And the group in the technology arm, they had improved stroke outcomes, improved thrombolysis rate. That's probably the largest trial largest RCT, I would say, in the use of technology right from diagnosis, treating them while they're in the hospital using algorithm-based protocol and outcome. So there is evidence, and also there are a few AI apps which has been tested in the stroke treatment workflow, where it improves the time to the door to needle time and improves the door to CT time, and thereby improves the outcome. And also through WHO, we have tested that in one of the African countries, Tanzania, where the tele-stroke model was implemented, and stroke unit was, the physicians were trained, and later on stroke unit was implemented and thrombolysis was started. And so there is evidence now, and also from Tezpur, I think the Qure has the data that they are analyzing from the Tezpur Baptist Hospital before deployment of the app and after deployment, and they are working on the publication. So definitely we have evidence that technology, particularly looking at low-cost technology, when we want to scale up programs in LMICs, we need to look at low-cost technology. In terms of rehabilitation, the caregiver trained model, which we tested in a 10 trial in India in 14 centers, even though the trial was neutral, but this was a model that was accepted by the family and the caregivers. So what we have done, what we are doing now is we have designed a 10-2 trial where we are developing a tele-stroke rehab platform. Dr. Dorcas Gandhi, who is with me, she's got a grant from World Stroke Organization, and we are going to develop that program and also look at the acceptability and feasibility of that program in the next 1 year. Maybe if we get funding, we can do the RCT. And the one Dr. Khurana mentioned, that trial also will be very informative. We'll be able to really work on the telestroke rehabilitation and community integration, empowering the caregivers at home to take care of them, particularly some of the basic aspects which can reduce the complication of stroke, and thereby it can improve the stroke outcome. So these are the ways that we can use technology, available evidence from both developed as well as developing countries, also in rehabilitation.
Thank you, Dr. Pandian. I'll move on to some of the very interesting questions from our audience today. The first question, I can't get your name, but talks about the role of technology in advancing thrombolysis access or acute stroke intervention in remote and underserved areas. I know that we already sort of touched upon that in the last few minutes and some of the questions, but if you would like to add anything else to this specific question, please go ahead.
Yeah, I
Dr.
think
Khurana, would
the
you want to take
telestroke is a way to go
an attempt at
for remote areas, access to stroke imaging, and also clinical details. Simple technology is sufficient to handhold them to decide on whether the patient is eligible for thrombolysis or not. And already models are available, and telestroke is a way to go. Yeah.
Thank you, Dr. Pandian. Dr. Khurana, do you want to add anything to this?
I think we've discussed most of these things, and so telemedicine, and in addition, we could again think of technologies which can link up hub and spoke directly, and something which currently is missing is the involvement of the end user. So right now, most of these technologies are only connecting hospitals or healthcare physicians. I think we need to develop certain technologies where the end user or the patient is empowered, who can, and that's happening though. I've heard of programs where detection of the stroke happens based upon detection by the phone that the stroke may be happening to that patient, and that alerts the system. So things like those need to reach out, technology in those ways, and that would be really, I would say, very, very instrumental, especially in remote areas where the detections are low. So that kind of a study done in remote areas would be really worthwhile.
Right. Thank you. Moving on to a slightly broader question from Robin. He's talking about, I think this I'll redirect it to Dr. Pandian to begin with. He says that in your exploration of national policies for stroke care, how do you propose addressing socioeconomic factors that contribute to disparities within stroke care outcomes? I think you've already addressed the national policies, but if you could throw some light on the disparities aspect in outcomes that are derived from socioeconomic underlying factors, that would be very helpful. And if you can think of how policy can play.
Yeah. So I'll start with the what data that we have in terms of long-term outcome of stroke patients. We have 7 years data, and also from Ludhiana population-based stroke registry, we had 6 months and 1 year follow-ups. And if you look at the Kolkata, the door-to-door survey done about 15 years ago, they have a long-term follow-up of 7 years. by 1 year, half of the patients die. And similar thing, and at least about 20-30% have recurrent strokes. So recurrent stroke is the main reason for death. And same thing with Ludhiana. As per the registry, population-based stroke registry, we had 1 month follow-up, but we did a 6 months and 1 year follow-up, telephonic follow-up. And again, the half of the patients are not alive at 1 year. So it reflects on the disparities in terms of access to care. And even in the Ludhiana population-based stroke registry in the urban area, the patients who went to the government hospitals had poor outcome. So you can see in the disparity in healthcare. So that is where, one is patients have stroke, they may get acute treatment, they may be getting thrombolysis or not, but the community integration and follow-up, their post-stroke issues like depression, anxiety, like complications like PET sore, deep vein thrombosis, swallowing, if they are not addressed, then no, they are going to die because they are not taken care, particularly people who are not able to walk and they are bedbound. And that is again the socioeconomic status. So how can we address that? At least acute care, we have Ayushman Bharat. Now we have district hospitals in many states offer thrombolysis. Tamil Nadu, Kerala, Tamil Nadu, we have the Tamil Nadu accident and emergency care. It combines heart attack, stroke, and trauma. Tamil Nadu, trauma and accident. Where these district hospitals, thrombolytic agents available, they have an app which is GPS enabled, and they can identify which is the nearest stroke ready center. So Kerala also has similar model, and in terms of access to acute care disparities, people who can't afford, they can go to government hospital. In states where Ayushman Bharat is rolled out very well and it's successful, people have access to acute care. What is lacking is the post-stroke care. That is where we have major disparities in terms of providing care to these patients. So that is where this telestroke and empowering community health workers, the caregivers, we need to really work hard towards that direction.
You're absolutely correct, Dr. Pandian. Thank you for highlighting the difference acute and post-acute care and how that impacts based on socioeconomic factors. One of our other audience members is asking something in line with this. And Dr. Khurana, if you could share your thoughts about engaging or empowering community organizations or community leaders in either the early prevention and early interventions or post-stroke care. What mechanisms or initiatives can be taken for planning? Of course, not an overnight change, but the long-term change in the stroke care scenario. If you have some ideas that you've already implemented or you would like to implement, please share some.
Well, definitely community leaders play an immense role. That has been suggested earlier. In fact, if I'm not mistaken, in places like Kerala, this has been attempted and has been put forth as an idea to use religious leaders, for example, in their temples and various religious places. They can put forth the idea of how important it is to control risk factors. That's one of the ways community leaders in different forums can be utilized and they can be involved. And that's one of the ways we even try to bring the attention to the risk factors in stroke and the damage which stroke does to the communities by also involving our political leaders. So they also play a role, at least in highlighting this fact and by providing solutions and looking for solutions. So community leaders do play an immense role, and even within the community, we should be looking for champions. So one of the biggest champions would be stroke survivors themselves, and patient groups. Those are still there. That's a growing population in India. We have patient groups which are coming up, so they play a major role. And I think that's one area which should be further well developed, to have patient groups who can propagate how important it is to know about strokes and treat them early. And that's mostly about all the, I think, integration of various aspects of community into the awareness.
Yeah, can I add to this
Please go ahead.
discussion? See, the community leaders' engagement is very, very important, and even in other countries, if we look at a lot of these advocacies are done by patient support organizations. It's not the professionals who are doing.
Absolutely.
So they are so strong, their voice is so strong, and they can access the parliamentarians, and they can really impress upon. So in India, we need to develop that. There are some stroke support organizations in southern part of India and also in North India, but they are still not strong. We need to develop in across the country. So that is how we can bring in awareness, and they can be involved in reaching out to the community leaders, particularly in the villages, and so there's a lot of things we can do. But I think we need to really mobilize the patient groups.
Exactly.
Absolutely. Dr. Pandian, I'll ask you one last question from the audience before I take up an interesting closing remark for both of you for this session. Rajiv here is asking us about type of certifications used for stroke centers, percentage of hospitals, or at least an indicative number of hospitals that are using tenecteplase. I'm sure the number may not be handy, and also the number of hospitals or percentage of hospitals that are able to perform thrombectomy today. If you could share some data or insights on that, that'd be helpful.
Yeah, the type of certification, it is based on the WHO roadmap. We divide the stroke systems of care and the centers into three categories. One is minimal services, that is like a primary health center where they can, what they do is rapid recognition of stroke patients, stabilize and refer these patients. Then essential stroke services like a primary stroke center where there is a physician or a neurologist who can rapidly assess these patients, provide thrombolysis facility and stroke unit care and a little bit of rehabilitation. And advanced stroke center is where everything is available, including thrombectomy, neurosurgery, full-fledged rehab, and follow-up care. So these are the three categories that from the WHO NABH program that we certify. The second is what percentage of hospitals are using TNK. So we don't have data, but I can say that the thrombolysis capable centers in India, it is more than 1,000. We have published a review paper in Lancet Regional Health Southeast Asia last year in October. More than IVT, I think around 1,500, if I'm correct. More than around 1,500 IVT capable centers in the country. Thrombectomy centers around 450 EVT capable centers in our country. But percentage is very difficult to say, and maybe Dr. Dheeraj Khurana also can add to this.
I think we don't have the exact numbers, and Dr. Pandian has referred to the approximate numbers, I think. But the thing is, like, it's dependent upon the expertise, which is now growing, and more, I'm sure the thrombectomy centers are still mushrooming because a good number of neurologists in India are getting trained in intervention. That's been the most limiting factor, is the availability of skill in the thrombectomy. So that, I'm sure, is increasing at a very rapid pace. And there is already a global program, the MT 2020, which is looking into greater access of thrombectomy. And they probably would have better figures in terms of knowing how many are currently there. But definitely the numbers are increasing.
Absolutely. I recently heard anecdotally around 3,000 to 3,500 trained interventionist or operators are present in India, and there are efforts to build that rapidly, but that's not a published number.
But
But
that would
coming to
include, I think, both radiologists and
Yeah.
neurologists, because we don't have as many
yes,
neurologists. 3,500 is a
that is
big
right.
number.
Yes, I think it includes both sets. Um, Great. So coming to the end of this very interesting and engaging session, we understand that the challenges are many, especially in a country as large as India. Quoting what you were saying, Dr. Khurana, every state is almost as large and as complex as some countries in the world. So it is not easy um, to model something absolutely based on Western guidelines in a country like India. But I would like you both to share what are your um, thoughts around something unique that India has built in terms of stroke care management or the resilience that it has built that is unique to solving India's challenges. Things like community-based rehabilitation that I had mentioned briefly, the physician-led stroke model, Dr. Pandian, that you were talking about, and some of the unique things that Tamil Nadu and Kerala governments are also doing to improve the access are truly local innovations that cater to our needs. But in each of your minds, if you were to pick one thing that is of interest or that is unique that India has solved for in stroke care, that would be great to hear from you. Dr.
Yeah, I
Pandian, do you want
think,
to go first?
yeah. So the first uniqueness I would say is um, a public-private model. In Punjab, the CT scan. So to diagnose a stroke, you need to have CT scan, our MRI scan. So that is a big investment. Uh, I'm not sure about other states in our country, maybe Tamil Nadu and Kerala. Besides that, every district hospital to have CT scan. This is the great model in Punjab. PPP model. A private player is the CTs outsourced to a private player, and they install the CT scan in the civil hospital, the district hospital. So that is a great model, which many LMICs can follow. Where the government does not have funds and the private player comes in, and so that is probably one great model that India has shown, and this can be replicated in other states. Like for example, I was talking to some other people in UP. The government does not have money, but we already have a model here in Punjab. You need to bring in some private players, and this particular private scan groups, they are across the country. So at least patients will get a rapid diagnosis of stroke, and we can take on from there whether to thrombolize or not to thrombolize, and so this is something very unique for from India, I would say.
That is definitely unique, and it has been used in other areas as well. Um, Thank you for sharing that, Dr. Pandian. Dr. Khurana, what comes to your mind when I ask you this question?
So in my mind, I think one of the major advances, or you might say, major change which we have witnessed over the years. In fact, Jeyaraj is responsible for that too, is the network of stroke trials, which is now being strongly funded by the ICMR and the Government Ministry of Health. I think that has led on to big changes, and that's where I look forward for the future, for multiple clinical trials happening in our country, which was not a possibility in the past. So we're getting multi-center clinical trials, which we have always been looking to up to the West, at least in LMICs, focused trials, which focus chiefly on our scenarios and our clinical problems. I think this is something big and strong that is going to emerge as far as clinical trials results applicable to our populations as well as the other LMICs. Now, for example, China comes up with so many clinical trials. Every month we have something getting published. But for India, this is going to be, I think, when results are soon going to come out for major trials. and we hope to establish and make a mark in our own local clinical trials.
Absolutely. That could be extremely powerful for new evidence building and charting the path forward as well. Thank you so much, Dr. Pandya and Dr. Khurana. It was an absolute pleasure and a great learning experience listening to both of you talk about this subject that you've worked extensively in. And
There's,
it was great for Qure to be able to host you as well. Thank you so much for your time.
Thank you.
yeah,
Thank you.
thank you.
Thank you.
Thank you very much. Yeah.